You.
Yes, sir. Hello, sir.
Anjali.
Sir. Hello, sir.
Hello,
Dr. Anjali.
Madam, hello.
Yes. Can you just introduce yourself?
Okay, ma'am. Good evening, respected teachers and my dear friends. Ma'am, myself, Dr. Anjali, second year postgraduate student from Malabar Medical College.
Okay, so your exam is in third year, isn't it? So you're just second year.
Yes, ma'am.
Okay.
Anjali.
Yes, sir.
Your video is on.
Sir, in the screen I can only see my
Yes, sir.
presentation, sir.
We can partly see her.
Yeah, we can see her.
Yeah, we can see her. Yeah. Anjali, you can start.
Okay, ma'am.
Yeah.
Good evening. Presenting the case of Mr. Kasim. He is 63 years old male, fishmonger by profession, hailing from Vadagara. Presented with chief complaints of change.
Wait, Anjali.
Sir.
Hello.
Hello, sir.
Can you hear me?
Yes, sir.
Aju.
Yes, sir. I can hear you.
Aniraj. Sudhya.
Yes, sir. I'm
Okay.
here.
So today there are some technical problems.
Okay.
Good evening to all of you. And today's star of the evening is our bright student Anjali Gangadharan. Don't be under tension, Anjali. You have 2 external examiners and 2 internal examiners. Externals, you may not be knowing, but I know them very well. We have Suja Sridharan. She is the professor, and she was the HOD of KMC Mangalore. She has done a lot of in the field of otolaryngology. She is more interested in the pediatric laryngology as well as cochlear implantation and head and neck cancer surgery. And we have Kailesh Pujari, who was the head of the department of Kasturba Medical College, Manipal. He is a professor there. And he has been, our Sandeep was there for the examinations. You have 2 eminent. Sandeep has not joined.
Yes.
Sandeep?
Yes, sir. Yes.
So I proudly present before you Anjali Gangadharan. Now Anjali can start. Okay.
Sir, presenting the case of Mr. Kasim. He is 63 years old male. He is a fishmonger by profession, hailing from Vadagara. Presented with chief complaint of change in voice for 2 months. History of present illness. Patient who was apparently normal 2 months back. Presented with change in voice. Started along with an upper respiratory tract infection, gradually progressed, later became persistent. It was hoarse in character. History of voice abuse present because of his profession. No diurnal variation. No history of voice fatigue, difficulty in breathing, exertional dyspnea, noisy breathing, cough on swallowing. No other aggravating or relieving
Anjali,
factors.
can you, excuse me, can you go a little bit slowly? Show that previous
Okay,
slide. Read it a
Sure.
bit slowly, please.
Okay, ma'am. Ma'am, presented with a complaint of change in voice. It was started along with an upper respiratory tract infection, gradually progressed, later became persistent. It was hoarse in character. History of voice abuse present because of his profession. No diurnal variation. No history of voice fatigue, difficulty in breathing, exertion or cough on swallowing. No history of pain during phonation, chronic cough, fever, evening rise of temperature, night sweats, foreign body sensation, throat, neck swellings, or no history of difficulty in swallowing, pain during swallowing, or trauma to head and neck region, slurring of speech, no history of regurgitation, nasal regurgitation, weakness of limb, no history of loss of weight or loss of appetite, no history of ear pain, sneezing, postnasal drip, mouth breathing or snoring, spitting of blood-stained sputum, bony pain or abdominal discomfort. History of past illness, similar or significant illness in the past. History of left-sided facial weakness for 35 years, no documents available. No history of diabetes, hypertension, tuberculosis, coronary artery disease, chronic obstructive pulmonary disease, bronchial asthma, drug allergy, bleeding disorders, or fever with rashes in the past. No history of any surgeries or irradiations in past. Personal history, cigarette smoker with 30 pack years, using 1 pack per day for past 30 years. No other addictions. Having mixed diet, regular bowel and bladder habits, sleep and appetite normal. No
Anjali,
significant family history.
Anjali,
Yes, sir.
Anjali, ആ മൈക്ക് കുറച്ചുകൂടെ അകത്ത് പിടിക്കുക. ഇടാന്ന് സൗണ്ട് ഇല്ലാതെ പറ്റില്ലേ?
Sir.
Ah.
No significant family history.
No, now it's not audible.
No significant family.
Volume.
No significant. No, sir, is it okay now?
It's okay now. So you can just go on to the history again.
Yes, sir.
So that the examiner should understand. So be a bit slow.
Sir.
Okay.
Anjali, why did you ask for a diurnal variation?
Sir, in case of chronic laryngitis, tuberculous laryngitis, there will be early morning worsening of hoarseness of voice. Later on progressing, there will be improvement in the symptoms. But in case of vocal nodule, vocal polyp, etc., because of the voice abuse during the evening period, patient will complaining of more worsening of symptoms.
Okay, so in this patient, the voice change from the beginning till the time that you have seen him, the voice. So there was no time when it was getting better? No.
No, madam. It was gradually progressed. Started with an upper respiratory tract infection noticed initially. Later, when the infection subsided also, he's having the same symptoms.
Okay, what is this last sentence that you have written, hoarse in character?
Ma'am, the change in voice can be hoarse, breathy, or harsh in quality.
If it is harsh also, it will be hoarse, isn't it? Do you have to separately say it is hoarse? And will the patient be able to make out?
In case of if it is a case of glottic pathology, patient can have a hoarse
That is
character of
true.
voice.
I am not saying
And
I'm not
nasal
denying that.
pathology patient
Yes,
will
but will the patient be able to make out? I think that is your call when you are examining the patient to say whether it is a hoarse voice or it is a hot potato voice or whatever you want to call it. For the patient, it is just a change of voice, isn't it?
Yes,
So the other things you will have to be able to tell during examination. What is a voice like? Okay, so this pose in character, what is the character of it to get from him is a little difficult, I felt. Now, you have written history of vocal abuse. So what is the sort of voice abuse that is present?
Because he's a fishmonger, so he want to use his voice excessively and for a long duration, mainly in the daytime.
Okay.
What do you mean by abuse? What do you mean by vocal abuse? What is vocal abuse? What is overuse and what is misuse? There are three terms which are used for this.
Right.
Vocal abuse, vocal overuse, and vocal misuse.
Sir, I don't understand the question, sir.
Okay, you use the word vocal abuse, right?
Yes, sir. Is using.
What is the other term that is thing? There are other terms like vocal overuse and vocal misuse.
Yes, sir.
What is the what is that for? What do you mean by that?
Misuse can
What
be
is vocal abuse?
misuse is improper voice production, sir. Patient may use a excessively high pitch voice or excessively low pitch voice
Okay, like
Here,
mimicry.
abuse is talking for a prolonged hours.
Okay. Abuse when you shout and all that is a mode of abuse.
Yes,
See, what is the other thing you ask when there's history of you're suspecting vocal nodules? What are the other history you'll get if you're suspecting vocal nodules? This is a
what is his
persistent in voice.
profession?
Yeah. What is the other thing
The
characteristic in the
voice
voice you'll ask?
fatigability.
Yeah.
The Mm. Okay. So and I think you asked about nasal regurgitation. So
Yes,
when
madam.
you are having voice change, is there yes, nasal regurgitation? I think you asked something else you kept in
Yes,
mind.
madam.
Anything else you should ask when there is change of
Because
voice?
ma'am,
Yes.
a
What
change
is
in
that?
voice can be associated with a cerebrovascular accident, can cause an acute change in
Okay, so
voice.
that is why you asked about slurring of
Slurring of
speech.
speech,
Okay,
nasal
but
regurgitation.
any vocal pathology can lead to some other problem like aspiration.
Yes, ma'am.
You don't know, it can be a vocal cord palsy also,
Yes.
isn't it?
Yes,
So
ma'am.
aspiration you have to ask. That is very important. Okay.
Mm.
Regurgitation, yes, you kept something else in mind, but aspiration is something that you need to ask. Foreign body sensation, neck swellings. So swellings are you thinking of?
Ma'am, sometimes the patient may present with a neck swelling due to a lymph node
Okay.
or a thyroid malignancy.
Neck node. Especially when there is a history, there is a change in voice and you have a neck node, then you should think about a supraglottic malignancy. Can you just go to the next slide?
Okay.
Okay.
Anjali, madam asked about aspiration. In your case, how is aspiration significant?
Because the aspiration can be due to any lesion, the hypopharynx, or whether there is any laryngeal incompetency can cause aspiration.
No, in a case of malignancy,
Or,
larynx, is aspiration important thing?
yes, sir.
In which or
Because in there is impairment, the three-tier mechanism causing impairment in the adduction of the vocal cords.
no, will it affect the management? In a case of malignancy,
There is
larynx,
aspiration, it indicates a dysfunctional larynx. So the organ preservation strategies sometimes will not work for the patient.
Anything else?
Extension to hypopharynx.
No, it also. Okay. Anything else? It will also give you an idea about the pulmonary
Yes,
status.
because patient will may develop an aspiration pneumonia, so the lung condition may be worse for the patient.
You said pack ears. Next slide, please. So what does it mean, pack ears? What is it?
Malignancy carcinogen of same upregulation causing a metabolite of alcohol, that is aldehyde, is also a DNA damaging property, and it will reduces the appetite of the patient, causing nutritional deficiencies.
Which can also maybe cause cancer.
Yes, madam.
Okay. So at the end of your history, what are you thinking of? What all possibilities are there? Because here you have a man who's been smoking 30 pack years, means 1 pack daily for 30 years. So what all possibilities are going through your mind?
Madam, only there is change in voice. It can be a benign pathologies like nodule or polyp.
No, you tell in an order. Differential diagnosis, you put an order 1, 2, 3, 4 like that. The first one should be the most likely. The first one should be the least.
Agent is addictive.
Malignancy. Number 1.
Yes,
Number 2.
TB larynx.
Yes, TB larynx. Possibility is there.
There will be a papillomas, adult onset papillomas.
Okay, you are thinking of papillomatous lesions on the larynx.
Yes, madam.
Okay. Fourth.
Or it can be other benign conditions like vocal cord nodule, vocal cord polyp.
Before that, would you like to put chronic laryngitis?
Yes, madam, chronic laryngitis.
Possibility is there, isn't it?
Yes.
Dr. Kailash?
Yeah. No, go ahead. Go ahead.
Okay.
Good. Yeah. Okay, can go to examination.
General examination, patient is conscious, oriented, and cooperative to time, place, and person, is moderately built and nourished. There is a left-sided lower motor neuron facial weakness. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Vitals, patient is febrile, pulse rate 70 per minute, normal volume, rhythm, and character. Blood pressure 110/70 millimeters of mercury, right upper arm, sitting posture. Respiratory rate 18 per minute, abdominothoracic. Examination of oral cavity and oropharynx. Lips normal. Lips oral commissure normal. Mouth opening is adequate. Gums normal. Buccal mucosa, nicotine stain present. Gingivo-labial and gingivo-buccal sulcus normal. Dental formula, there is 1011 in the upper half and 1001 on the lower half. Salivary duct opening is normal. Retromolar trigon and anterior two-third of the tongue, floor of mouth normal. Hard palate, nicotine stain present. Anterior tonsillar pillars, tonsils and posterior tonsillar pillars normal. Soft palate normal and mobile. Uvula central, posterior pharyngeal wall normal.
Zili, what is this retromolar trigon? How will you define it? And what are the models?
So it is a mucosa lined area behind the posterior last molar. It is bounded. Its base is formed by the posterior last third molar, and apex is the maxillary tuberosity, and medially the temporal ramus of mandible, and laterally the lateral ramus of mandible.
Okay, and what is the importance of retromolar trigon?
Sir, it is a mucosa lined area. So the early chance for if there is any lesion, malignancy can easily spread into the bone. And there will be chance for occult lesions that we cannot detect in the clinical examination.
Okay, hidden area.
Hidden areas.
Good. Go ahead.
Indirect laryngoscopy, base of tongue, both valleculae, median and lateral glossoepiglottic folds, both pharyngoepiglottic folds, lingual and laryngeal surface of epiglottis, both ariepiglottic folds, false chords, normal. There is an ulceroproliferative growth involving superior and medial surface of entire length of right vocal cord, extending to involve anterior commissure and anterior two-thirds of left vocal cord, impaired mobility of right vocal cord and normal mobility of left vocal cord, posterior commissure found normal, a phonatory gap present, glottic space adequate, both piriform fossa normal. This is the video laryngoscopy showing we can see an growth over the right vocal cord, entire length of right vocal cord, extending involving anterior commissure and anterior aspect of the left vocal cord also, with some mucosal changes over the posterior aspect also of the remaining part of the left vocal cord also, sir. And there is left vocal cord mobility is normal, right? There is impairment in the mobility.
What do you think is the
Can we see
cause?
the video?
What do you think is the cause for that impaired mobility? It is fixed or is it?
Impaired mobility is due to the paraglottic space involvement, leading to
okay, here it doesn't look like paraglottic space is involved. Anything else? Okay, yeah, go ahead. What are the other possibilities?
Sir, it can be due to cricoarytenoid joint fixity or recurrent laryngeal involvement, or sometimes bulk of the tumor can cause.
What is the possibility in this?
It may be due to the mostly can be due to paraglottic space involvement, sir.
Well, it's mainly medial, no, the lesion.
Sir?
The lesion is mainly medial. It doesn't seem to be extending laterally, at least clinically.
I can't get the question, sir.
Sir is saying that the lesion is medially located, doesn't seem to be ending laterally.
Do you find any irregularity in the cord?
Yes, sir.
What are the other things you look at when you are looking at the video laryngoscopy of?
Extent.
Is this a video laryngoscopy, rigid telescopy finding or flexible?
Sir, rigid endoscopy, 70-degree scope.
Okay.
There is some irregularity in the posterior two-third of the left vocal cord also, madam. There is some mucosal changes with congestion and irregularity.
Yes, because to me it looks as if both chords, at least till the vocal process, there is some irregularity. I mean, maybe I'm not seeing too well, but you all would have been able to see better because the resolution would have been a little lost on transmission. So sort of maybe anterior two-thirds, or at least from the vocal process on, and one right side definitely till the vocal process also may be involved, and anterior commissure. So tell us, at least theoretically, what are the reasons why a cord becomes less mobile?
Thyroarytenoid muscle involvement. The internal part of vocalis muscle involvement,
yes.
Or can be
no, thyroarytenoid is the medial part of vocalis muscle is the medial part of One then,
or the joint involvement, cricoarytenoid joint, or the bulk of the tumor can cause some restriction in the movement.
okay. And the last one is what you said, the paraglottic to ask you. Muscle involvement. Vocalis muscle as
Vocal
such will not,
muscle
but it's a
involvement.
thyroid muscle. You have to go laterally, it has to go, the tumor. So, but as such, the lesion sitting in the anterior commissure also, that may also be preventing the sitting
The
there.
bulk of man seems to be more because of that.
Yeah, that is what you're looking at this.
Cannot appreciate the subglottic extension, madam.
Yeah, but yeah. Okay, so okay then.
Madam,
Anything else?
Examination of oropharynx.
Yes.
Can I proceed to examination
Okay.
next, madam? Examination of trachea, central, laryngeal framework is normal with tenderness or widening. Laryngeal crepit, no palpable cervical lymph nodes, no other neck swelling, cysts or sinuses or scars. Examination of ears, pinna, preauricular area, postauricular area, normal on both sides, no tragal or mastoid tenderness, external auditory canal.
What did you look for in the laryngeal framework?
Laryngeal framework includes thyroid cartilage. We look for cartilage, playing of, and extra laryngeal spread. And
What is what is playing of cartilage? What does that mean?
There will be normally lamina will forms an angle of 90 degrees. And
Any other?
In history, or reason there can be a swelling the neck because of laryngeal malignancy.
thyroid membrane.
Yeah, more than which are the membrane?
Thyroid membrane.
Yeah, that can also present like a neck swelling.
So, Anjali,
Yes, ma'am.
so in this patient, if the tumor has to get, you see in your findings, how will it go become extra laryngeal? What is the route by which it can?
There is involvement of anterior from the anterior, from there at that side where the anterior commissure attached to inner aspect of thyroid cartilage, there will be absence of inner perichondrium, so it can easily spread through the thyroid cartilage and can present extralaryngeally.
Okay.
Or
any other way?
Madam, also there is a subglottic, that is anterior subglottic beds. It can reaches the subglottis and through the cricothyroid membrane.
Yes.
Can reach extralaryngeally.
So that is one way, because it can become translaryngeal, in the sense it can go up and down. If it goes up,
yes, madam. There will be petiole of the epiglottis just above the antecommissure and can reach the epiglottis from the pre-epiglottic space.
pre-epiglottic space.
The,
so that is one and another way. Then any other way? Laterally.
Through the paraglottic space, it can reach the ventricle.
No, through the ventricle it reaches the paraglottic space. Or yeah, whatever, and it reaches the paraglottic space. From there, it can become extralaryngeal again.
Posteriorly into posterior commissure.
Posterior commissure, will it become extralaryngeal?
No, ma'am. No, spread. Okay. What is a transglottic malignancy?
Okay, what is a transglottic malignancy?
No, 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 ma'am. No, spread.
Okay, what is a transglottic malignancy? 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 Okay, what is a transglottic malignancy?
Transglottic is the malignancy which traverses across the ventricle and can extend from glottis to subglottis, glottis to supraglottis, or from supraglottis to glottis, with or without extension of subglottis.
Yeah, but it should travel through the ventricle. The
Ventricle.
classical transglottic malignancy, it has to go through the ventricle and involve
And
2
involve
out of
both
3
glottis and
places.
supraglottis.
What is the nature of this transglottic malignancy? How does it
It's
present?
early early nodal involvement,
Yes,
madam.
early nodal involvement. And usually it
And
presents at what is the stage
extensively-
at presentation?
Level
Stage 3. Usually it cord will be fixed because it's transglottic, goes through the paraglottic space. So usually presents at stage 3 with the usually a node also, neck node involvement. Okay.
Giri, how will you know whether the ventricle is involved in your case?
There is fullness in the ventricle, sir.
Ventricular band fullness.
Oh.
Then
Paraglottic space involved impairment of mobility.
to the other side,
It will be just a higher level than when compared to opposite side.
there will be fullness of the false cords. Yes. Okay.
Okay. So in this patient, when you look at the glottic chink, you are deeming it adequate, isn't it?
Yes, madam.
So what is adequate glottic chink for breathing?
There is no clinically there will be no breathing difficulty or exertion, noisy breathing, and
For the
examination.
glottic
We can
chink,
see the
what should be the distance between the
exam.
vocal cords, anterior or
vocal cords.
posterior? Which is
And-
more important for breathing?
Posterior glottis.
So okay, posteriorly for adequate breathing. Now, we are not talking about voice
That's
here.
the principle
For
used for
adequate breathing.
chordotomy.
Okay.
To create a posterior glottic space. So airway is the less compromise of voice.
So,
Go ahead, yeah. Go ahead.
but I can't get the questions.
No,
No,
mine was only a statement. So yeah, I said that that was the principle. What you say, the posterior glottic space creating that is done in chordotomy for bilateral abductor
Kashima.
palsy. Yeah, so that's the principle of that. You does not affect the voice much.
Yes. Okay, go ahead.
Examination of ears. Pinna, preauricular area, postauricular area normal on both sides. No tragal or mastoid tenderness. External canal, binding membrane, test centralized. Absolute bone conduction normal. No spontaneous nystagmus. Fistula test negative. Facial examination. The left side there is absent forehead wrinkling, incomplete eye closure, absent nasofacial and nasolabial fold. This patient is unable to blow cheek against the resistance, and angle of mouth is deviated towards the right side. External nasal framework normal. Cold spatula test equal fogging both sides. Columella central, vestibule normal. Anterior rhinoscopy, deviated nasal septum with a spur to left. Posterior rhinoscopy, posterior end of nasal septum and turbinates, seen and normal. No paranasal sinus tenderness. Other system examination, respiratory system, occasional rhongae heard. Cardiovascular system, first and second heart sound heard normally. Central nervous system, higher mental functions normal. Left-sided facial paralysis present. Skull and spine, not deformity or tenderness. Gastrointestinal system, no hepatosplenomegaly. Summary, 63 years old male, chronic smoker, presented with change in voice for 2 months, hoarse in character and persistent with history of voice abuse. Also history of left-sided facial weakness for 35 years, no documents available. Examination showed nicotine stain over the buccal mucosa and hard palate. Indirect laryngoscopy showed an ulceroproliferative growth involving right vocal cord, anterior commissure, and anterior one-third of left vocal cord with impaired mobility of right vocal cord and normal mobility of left vocal cord with adequate glottic space and a left-sided grade 5 facial weakness. So the provisional diagnosis, malignancy glottis, clinically T2 N0 M0 stage 2 with a left-sided lower motor neuron facial paralysis.
Anjali, in your description of the lesion,
Yes, ma'am.
can you just go back to that slide? Okay, so when you're looking at it, it looked like ulceroproliferative growth, is it?
Yes, madam.
Okay. So is your differential diagnosis same, or is it, do you have a differential diagnosis now, or it is definitely looking like a malignancy?
Yes, madam. It is a case of mostly malignancy.
Okay, so that is still your first diagnosis, isn't it?
Yes, madam.
Can you tell me the types of chronic laryngitis?
Infectious cause and inflammatory. Infectious can be
No. Types of chronic laryngitis. I'm not talking about non-specific chronic laryngitis. There are some types, isn't it?
tuberculous laryngitis.
No, those are specific types. There is simple diffuse chronic laryngitis, chronic diffuse hyperplastic laryngitis. So there are some types of laryngitis. Do you know? Okay. Keratosis, leukoplakia, that is also a type of laryngitis. Okay, so there are 4 types of laryngitis. I think described and histopathologically described actually by Klein Sasser. So it's worth reading through that. Okay. So why did you say T2?
Madam, because there is impairment in the vocal cord mobility.
Okay. So how do you stage glottic malignancies?
Ma'am, at TNM staging, there are 4 stages. T1, it is limited to vocal cord. T1 limited to vocal cord is again divided to 1A and 1B. 1A is 1 vocal cord, 1B is 2 both vocal cords. T2 from it extends from extends supraglottically with the impairment in the mobility or extends subglottically. And T3 means there is limited to the larynx with the hemilarynx fixity, and there will be involvement of preepiglottic space, paraglottic space, or inner cortex of thyroid cartilage. T4 again A and B. In A type T4A, there is involvement. There is tumor extends out, breaches the outer cortex of thyroid cartilage, and becomes extralaryngeal and involves the deep extrinsic muscles of tongue, strap muscles, esophagus, trachea. T4B is involvement of mediastinum, encases carotid artery.
Okay. Others? Yeah.
Supraglottis.
Dr. Kailash?
Yeah, what would be on looking at this? What would be other differential diagnosis? You said earlier you mentioned malignancy and then tuberculosis. Anything else? Possibly chronic laryngitis.
So let us ask, there is any possibility of chronic laryngitis, like
From history, there is no history of any pulmonary tuberculosis, suggestive pulmonary tuberculosis, and in examination, there is impairment and ulcerative growth involving the cord, anterior commission opposite side, and if the patient is a chronic smoker also, so not like less likely for a tuberculous laryngitis.
Yes, sir. This point that you made, that because he's not having cough, that he should not have tubercular laryngitis. That is actually has been proven many times. Head and neck tuberculosis is many cases that we see now are extra pulmonary tuberculosis. They may not be there in the lungs at all. At least we can't find evidence in the lungs. Okay, so but we may find tuberculosis somewhere else in many head and neck areas. Okay, so it may be there or may not be there, but that doesn't actually exclude laryngeal tuberculosis.
How does it present? What are the findings? Laryngeal tuberculosis.
Weakness of voice, clinically patient will present with weak voice, impaired adduction of vocal cord.
Tuberculosis. Dr. Kailash is asking about tuberculosis. What are the findings in tuberculosis? Larynx.
Larynx. There will be congestion of the vocal cord and surrounding surrounding pale mucosa of the larynx, and there will be pyriform because of pseudoedema. There will be fold and interarticular mammaliations and granulation over the interarticular area and mouse nibbled appearance of vocal cord. There in the later stage there will be cricoarytenoid joint ankylosis and perichondritis.
How will you evaluate this patient?
First, we can proceed with the, we have done a video laryngoscopy. So next we can proceed with the,
What should you tell us, sorry?
So flexible nasopharyngeal laryngoscopy will be give better image because we can better subglottic extension like that can be seen in nasopharyngeal laryngoscope, flexible scope.
Anything else?
And as in rigid we are manipulating the clearly, it may causes the some impairment in the mobility of the vocal cord.
Yeah. So flexible probably would be a ideal this one.
Correct.
What about you said there's involvement possibility of the pre-epiglottic space sometimes in some laryngeal malignancy.
So what evaluation routine, what you'll do?
Baseline blood investigations to know the hemoglobin, any other liver function test, renal function test, serum electrolytes, and also chest X-ray.
Why chest X-ray you want to do? What all we are trying to find in this patient?
Because madam is a chronic smoker, we can look for any other malignancies, lung malignancies, metastasis, cavity.
Other lung malignancies means are you looking at another primary?
Second primary.
Yes.
Which should be better, CT or a chest X-ray?
Sir?
Which should you prefer to do, CT thorax or a chest X-ray?
Since the option there is CT thorax can
okay,
be
what
better.
are we look for in CT thorax? One you said is a second primary. Then you look for secondaries in lung. Then
any tuberculous cavities.
Okay, possibility of either past cavity or present this one, tubercular lesion of tuberculous function.
Lung metastasis from the
That
primary.
you mentioned. Yeah, that you mentioned. Second primary and lung mets you mentioned.
The COPD condition, tuberculous cavity.
Okay, that you mentioned. Okay.
Any mediastinal lymph nodes.
That is in some laryngeal malignancy, we can get mediastinal lymph nodes. Okay, then.
Patient if any a silent aspiration, we can see pneumonia.
Yeah, silent aspiration.
Pulmonary status lung patient we can assess.
We can also check, sometimes they can present with metas in the ribs also. So, yeah, that also will be seen on CT thorax. Next, what would you like to do?
Then after imaging.
Would you like to do a CT larynx or MRI of the larynx?
MRI is more sensitive than CT. So base of tongue vallecula invasion can better seen in MRI than that of CT.
In this patient, are you looking at more soft tissue? Which soft tissue you want to look in this patient?
Cartilage.
Which soft tissue?
Cartilage.
Larynx. Prevertebral fascia.
Wait, that is very far away, no?
You were saying all this time, we kept mentioning so many times the same area.
Yeah.
You didn't mention this quite often.
Ventricle.
Near the vocal cord, something else.
Arytenoid involvement.
Restriction in mobility. You kept on saying.
Paraglotic space,
What is it?
epiglottic space.
Yeah. Okay. Because immediately that will upstage a tumor also, by the way. So that is one area. Then you want to see subglottis. Thyroid cartilage you already mentioned. How will a neck node look like in CT scan?
Madam,
for that matter, MRI.
there will
Which
be
is involved.
spherical shape, irregularity over the surface, and the short digestive gland is be more than 1.5 centimeters, central necrosis, loss of fatty hilum, and peripheral rim enhancement.
Okay.
What would you like to do next?
Okay, after imaging, we can proceed with that and baseline blood investigations and imaging. We can proceed with the direct laryngoscopy with biopsy under general anesthesia, because we want to get a tissue diagnosis.
Which would be better, your direct laryngoscopy, microlaryngoscopy?
Microlaryngoscopy.
Why?
In direct laryngoscopy, we can probe the cricoarytenoid joint involvement, etc. can be assessed by probing.
That you can do while doing microlaryngoscopy also, in the process of doing that. Which will give a better view, especially when you want to see the anterior commissure, you want to see the ventricle. How will you see the ventricle? What are the methods of visualizing the ventricle and the subglottis? What are the methods of visualizing the ventricle and on the subglottis?
By lateralizing the true chord, we can false and true chord, we can visualize the subglottis.
What is your answer? Sorry, I didn't hear.
Madam, to visualize the subglottis, we can lateralize the false chord and true chord.
Okay.
To visualize the ventricle by lateralizing the false chord.
Hmm.
Anything else you can use?
Huh?
Still not sure. Anything else in addition to that?
Hmm.
Can you use an angled endoscope?
Okay, so we can use an angle.
You can pass it through the your scope also. You can pass through that an angled endoscope and see. Right?
So, yeah. So to know the true extent of the tumor, is there anything else if you have the facility, say you have any facility that is available in the world? So you feel that, 1/3, you said 1/3 of the cord is involved. So is there anything else you can do when you're doing Dr. Kailash said microlaryngoscopy, he said, anything else can be
Narrowband
done?
imaging.
What is narrowband
It is
imaging?
done to visualize the vascularity of the vocal cord using after staining the mucosa through Hopkins rod lens. We are visualizing.
Is it?
And because hemoglobin and after illumination, the hemoglobin will absorb a particular wavelength and will give a particular contrast when compared to normal area.
Yeah, but we don't stain it, no, separately. I don't think we stain.
No
Do
staining
we?
for that.
So
Yeah,
narrowband imaging.
No, madam, after illumination, the hemoglobin absorbs a particular, after blue illumination, blue hemoglobin absorbs a particular wavelength and can give a particular
Basically, you
contrast
see the
from the normal.
angio-architecture, the architecture of the vessels, either just beneath in the mucosa or just beneath the mucosa. Okay, so in that area, that is where the two filters are used, green light and blue light. Okay, so that will give you a better idea of where the tumor is going, especially if you are thinking of some surgical,
Intervention.
method of treatment. Yeah, intervention.
They're going to do a scopian biopsy, microlaryngoscopy and biopsy. Okay. Suppose this comes as squamous cell carcinoma. What is your possible treatment for this?
This is stage 2 tumor with histopathology for squamous cell carcinoma. We can either go for a radiotherapy or surgery.
What is the radiotherapy? What is the dose that is given?
For T2 glottic carcinoma, we can give a 70 gray radiation of 2 gray per fraction, total of 30 to 35 fractions for 5 weeks a week for 6 to 7 weeks.
Okay. And you mentioned about surgery. What surgery?
This is a case of stage 2 malignancy, but considering the age and he's a chronic smoker and clinically there is some impairment in the lung function. So the partial laryngectomies will not benefit for this patient. So we want to go for a radical surgery, near total or total laryngectomy.
You cannot do a radical surgery for this. When will you do radical surgery?
Sorry, total laryngectomy.
When will you do a total laryngectomy? What is the indication for doing a total laryngectomy?
For dysfunctional larynx, compromised laryngeal structure, compromised laryngeal function, failure of organ preservation.
Means failure of organ preservation means?
Sir?
What do you mean by that? Failure of organ preservation?
Sir,
One is, dysfunctional larynx. Yeah.
Sir, organ preservation means radiotherapy is an option of organ preservation, partial laryngectomy. After a radiotherapy, patients showed a recurrence. We want to
a recurrent disease, radio recurrent or residual disease. You mean a radio recurrent residual disease?
Yes, sir.
Okay. Any other thing? Any other indication?
Patient is not a candidate, cannot go for a chemotherapy for any renal compromised patient or not responding to chemotherapy.
Means what? When will you do a total laryngectomy? What are the indications?
If there is compromised laryngeal structure, that is, there is
Yeah, that is said. Dysfunctional larynx is said. Radio recurrent residual disease. Gross disease is there. Yeah. What else?
If other conditions like miscellaneous conditions like crush injury of the larynx and
No,
other
laryngeal malignancy. Laryngeal malignancy.
non-squamous malignancies like adenocarcinoma, adenocystic
Okay,
carcinoma.
in squamous cell carcinoma.
There is compromised laryngeal structure function. Failure of organ
There is gross
differentiation.
cartilage involvement, extralaryngeal spread. Would you like to do a
Sir, that is compromised laryngeal structure. That is, if there is involvement of thyroid cartilage, goes extralaryngeally, a cricoid cartilage,
okay? So
and if there is patient is having intractable aspiration.
So all this doesn't come in your for a reason for doing a laryngectomy in your current diagnosis.
Sir, this is because he's having a elderly patient with some compromised laryngeal structure, there is compromised pulmonary function, because there is on examination there is a wrong.
So you'll have to do a pulmonary function test before that.
Yes, sir.
You have to do So what I said was, if you had to do a surgery, what surgery would you like to do? In this case, probably a better choice would be a radiotherapy. But in case you need to do surgery, what surgery would you do? Suppose this patient had radio recurrent disease.
Radio recurrence, sir.
Still that disease. Yeah, and it's not involving the cartilage. Patient has no aspiration.
A supracricoid partial laryngectomy.
This is involving mainly the. What are the types of cordectomy? You know.
Subepithelial.
Type 2.
Type 3 transmuscular. 4 is total cordectomy. Then extended cordectomy with ABC. A is involvement of anterior commission opposite vocal cord. B subglottis. C arytenoids posteriorly.
What about supraglottis, ventricle? Then extend to the ventricle.
D. Extended cordectomy type D.
Is there a type 6 now?
Bilateral. Anterior commissure cordectomy.
What do you mean by anterior commissure cordectomy?
Because only anterior commissure and anterior aspect of both vocal cord are removed.
Anything else along with yeah?
So, Anjali, when you're making decision about cordectomy, is there any other pre-operative investigation that you can do, which may help you think that yes, the cordectomy that I have to do can be a, it need not go through the muscle, it need not go through the vocal ligament.
Madam,
any preoperative, any other investigation is there that can be done to help you assess whether the tumor has gone through the vocal ligament.
Yeah, some investigations you check for laryngeal movement, isn't it?
Can check the surgery movement, the way so that with the filtration, whether it involves the muscle. You're taking the patient to biopsy, so that's a good time to check all that. Can be there, but roughly you can get an idea whether there's infiltration. So what Dr. Kailash is asking is this a patient where you can do transoral microsurgery, laser excision, or even
Correct. There is because of the
life?
involvement of
Mm.
anterior commissure and opposite up to 1/3 of the vocal cord is involved.
You feel it's not a good candidate. He's not a good
Yes,
candidate.
madam.
That's what you feel, isn't it? Why? What is the involvement of anterior commissure? What has that got to do with transoral laser surgery? Does it change the prognosis? Involvement of
And
anterior
sometimes
commissure?
we cannot assess the extent. There is chance for recurrence.
Yes, the chance of recurrence is more when anterior commissure is involved, retinoid is involved. And here there is extensive involvement. Other side is also involved. So what is your plan for management? What, in your opinion, what do you think is the best plan for management of this patient?
Radiotherapy is better for this patient.
Yeah. Okay, whatever you say, you have to give us the supporting argument, and you should say you should be firm as to your
Yes,
your
madam,
method of
because
management.
he's an elderly patient and
Okay.
and with a poor pulmonary reserve because of his addiction, and so we can better go for a radiation therapy. So if there is any recurrence later, we can go for the surgery can be used as a reserve.
Mhm. Okay. What is verrucous carcinoma?
Madam, it is a type of squamous cell carcinoma, which is a slow-growing variety with a exophytic warty appearance, slow-growing malignancy, well-differentiated type of
So if
squamous
it
cell
comes as
carcinoma.
verrucous carcinoma, this patient, it comes as verrucous, then what will you do?
Then radiotherapy will causes change in the histopathology because they become an anaplastic type. So we want to go for a surgery.
And then you can consider surgery. That's a little bit controversial about it, but whether it is changing or whether there is in any other place there is squamous cell malignancy, but still yes. So that is one of the reasons why you can say that I would like to go for surgery if it comes as verrucous. But I don't know whether that is so much. Yeah. So what is concurrent chemotherapy?
Madam, concurrent means along with the radiation therapy, we will give chemotherapy as an induction.
Is it as an induction? Induction chemotherapy
It is
means
first
what?
chemotherapy, later radiotherapy. Sir.
Then it is not concurrent. It is yeah. So that is first chemotherapy and then so concurrent. So what are the agents used for concurrent chemotherapy?
Cisplatin, 5-fluorouracil, docetaxel.
Okay. Anyone else?
How will you follow up this patient? Patient has completed radiotherapy. How will you follow up this patient?
First 6 months a monthly follow-up. Thereafter 6 monthly follow-up. For next 1 year 6 monthly. Then yearly follow-up.
What complications can be there from radiotherapy? Can you enumerate?
Madam, there is
because you said no very high dose. You said 60 grays. Huh? So
there are acute and delayed complications. Acute can be radiation dermatitis. There will be erythema, hyperpigmentation, desquamation, and mucositis, stomatitis, dysphagia. Late sequelae can be there will be dysphagia due to skin fibrosis, stricture formation, xerostomia, and
where is the stricture? Where do you get the stricture usually? Dysphagia, yes, you're correct in that you may get a stricture, but where do you get the stricture which causes dysphagia? Usually when you give radiation to the laryngeal area, hypopharyngeal area.
Post-cricoid area, madam.
Yes, post-cricoid. Okay. Then what are the other complications?
Osteoradionecrosis of the mandible, arytenoid necrosis, laryngeal edema.
Okay. Then
Second, radiation-induced malignancies.
that is a little late. Okay. Then anything else? Anything to the spine? Any neurological problems?
They will damage the nearby structures. Neuropathies.
Lermite syndrome. There is a syndrome like that.
Lermoid
Lermite syndrome. Yeah. What is that?
No, no.
Okay. Oh, so it can have some neurological problems also. Isn't it? Including transverse myelitis, Lermite syndrome. What happens? What is any changes can happen to the voice? Late changes?
Because of stricture fibrosis.
Because of fibrosis. Okay, you can have some late changes to the voice. So voice, acute phases is not so bad, but after that, after 1 or 2 years, it may become very bad. Anything else?
Radiation complication.
No, Dr. Kailash or anyone else?
What do you mean by fractionation in radiotherapy?
Sir, there is a hyperfractionation because we are giving a low dose multiple times a day. That is hyperfractionation.
Any other fractionation?
Hypofractionation. Hypofractionation.
What is accelerated fraction? Okay, you have to read a little bit more about radiotherapy. IMRT, what is IMRT?
It is intensity modulated radiotherapy. A simultaneous integrated booster given. That means in most tumor area we are giving a more dose, and adjacent sensitive areas like spinal cord and parotid like sparing and nearby structures we will give.
You give lower dose, okay?
More dose at a tumor site with a periphery, with a less dose over the periphery.
Okay.
What are the barriers for spread of malignancy in the larynx?
Intrinsic ligaments, quadrangular membrane, conus elasticus.
Anything else?
Thyroid membrane, cricothyroid membrane, vocal ligament.
If a patient with laryngeal malignancy comes with aspiration, what are the possible reasons for the aspiration?
So aspiration can be due to impaired vocal cord adduction, or due to there is laryngeal spillover due to any lesion in the hypopharynx, or due to loss of sensation. if it is a patient is tracheostomized the patient, it can be due to inability to produce a positive subglottic pressure.
What about a fistula?
Pharyngocutis.
Tracheostomy fistula. Tracheostomy fistula. Yeah, yeah. On the bulk of the tumor, which can cause a spillover. We mentioned that, I think.
So if you have a patient post-operatively who's aspirating, so how do you decide what feeds can you give him? Is there any test that you can do? What you can safely give him? Okay, you have a patient, like sir said, who's aspirating. So if he's aspirating before you give radiotherapy, definitely he'll aspirate afterwards. So how do you decide what food can be safely given to him? Any test is there which can be done? Peace.
Like fiberoptic endoscopy evaluation of swallowing.
Yeah. Can that be done? So you can give different consistencies of food and for the patient. Yes. And you can even, the swallowing therapist can start some maneuvers for teaching the patient how to do safe swallows without aspiration. Correct, no? Any other questions?
Any doubts from the other participants?
What are the following methods to prevent aspiration? What is your supraglottic?
I think the question was, what are the maneuvers to reduce aspiration? Swallowing maneuvers are there?
Don't know, sir.
So if this patient, say you give radiotherapy and then the patient after 2-3 years he comes back with malignancy, then what will you do?
Madam, it is a case of recurrence. So we want to go for a total laryngectomy.
You would like to go for
Can
a
you
total.
radiate? Can you radiate the patient again?
It indicates that there is a radio resistance. For radiation recurrence cases, we are going for.
Why is that?
Radiation, the best output from radiation can be done in the first time.
That's not the answer, isn't it? Can you give like that every 2-3 years radiotherapy? So you can't do that. So you can't repeat radiotherapy. I think it till 8 years, isn't it, Dr. Kailash? 8 years we cannot. That is my understanding. I don't know whether new methods, but still, I don't think we are giving before 8 years. In fact, that is one of the disadvantages of using giving radiotherapy, because that modality is over for the patient, not only as far as this malignancy is concerned, some other malignancy that develops in that region, because he's a smoker and there's field cancerization. Some other area also he can get malignancy. So, but once you use radiotherapy, that modality is over for the next so many years.
So they say probably in T1 lesions, probably cordectomy would have better thing. Preserve the.
And many people, many people may do this lesion also, depending upon how in MRI you may get an idea. Okay, so then you will do. What are the what complications can you expect?
There will be fibrosis, madam. So better plain. We cannot tissue planes cannot be easy to
Yes,
identify.
yes.
And
Tissue planes,
there-
tissue margins not easy to identify. Yes. Then,
there will
what
be
is the
edema.
dreaded complication which you have to explain to the patient? Patient's relative. That is something that you can anticipate if total laryngectomy after radiation. Dr. Kailash was mentioning, no?
Fistula, madam.
What fistula? Which one?
Tracheoesophageal patient can develop that.
Not
This is
tracheoesophageal.
different.
After surgery, the patient can develop pharyngocutaneous fistula.
How do you prevent that?
Laryngocutaneous.
It can be prevented if the pharyngeal mucosa is not sufficient to create a neopharynx. We want to go for a pharyngoplasty with the pectoralis major myocutaneous flap or delta pectoral flap.
What about the skin? Anterior skin.
There is skin involvement. We want to take a distal flap like radial forearm flap or anterolateral thigh flap. For defect to come clear.
No, what Dr. Kailash is asking is what you're going to do about the skin. The skin will be in a very bad shape after radiotherapy. Okay, so that skin is a very big problem when you're doing total laryngectomy after radiotherapy. That vascularity that you want it to give to the underlying closure will not be there. So what to do about the skin?
We can for madam cutaneous radial forearm flap.
Okay, so you want to put a flap, no? Yeah. Okay, but there are some things nearby which can easily be mobilized. A DP flap. Okay. Some vascularity, yeah. So can you tell me some methods of rehabilitation of voice after total laryngectomy?
Madam, there is esophageal speech and artificial larynx, or we can use a tracheoesophageal puncture. It can be primary or secondary. After
so how do you do this esophageal speech? What is the principle behind that?
it is in esophageal speech, the source of air is from esophagus, and during controlled, patient will inject or inhale the air, and by controlled regurgitation, it will causes vibration over the pharyngoesophageal segment, and patient can articulate with oral cavity and oropharynx.
So what are the disadvantages of esophageal speech? What are the problems?
Patient cannot occur it easily.
Okay.
Anything else?
The quality of voice is not good.
Anything else?
It may cause any pharyngeal,
Have you heard esophageal voice?
videos and
Yeah, it may be not there now, I suppose. People may not be going for it. So Dr. Kailash is asking what are the other disadvantages of esophageal voice?
it is not easy to acquire the skill for patient. It is more distress for patient.
When you hold the artificial larynx, no,
Mm.
how long can the person speak?
Sir,
How long can the person speak?
how long? Mm.
And now we compare that with esophageal speech.
The problem with the artificial larynx, there is a monotonous voice only.
Okay.
Hmm.
Mm.
So esophageal speech with one belch, it is belched out,
okay,
no?
sir, okay.
With one belch, how many words? That's what he's
Okay.
asking. How many words?
Mm.
How much capacity of the esophagus? What is the capacity of the esophagus? How much air can it hold? Capacity means how much air can it hold? What is the tidal volume? Normal tidal volume?
500 ml.
Yeah. So esophagus, how much can it hold? About 150 ml. Okay. So only 5 to 6 words per belch is possible. That is what how long he can speak means that is the answer to that.
Mm.
Okay. So what about tracheoesophageal speech then?
It is a lung-powered speech. So it is a better quality of voice. Can be a primary and secondary.
Kevin?
Sir?
No, go ahead, yeah.
Primary tracheoesophageal puncture is the puncture we are done at the time of laryngectomy. And if we are planning for a radiotherapy for this patient, so we want to do a secondary tracheoesophageal puncture.
So the same question, how long can he speak?
It is a
Each
lung-powered speech. So
he may be able to do as much as 30 seconds, 30 words per breath. Okay. So almost like normal. Even when in our one expired volume of air, we may also be able to speak 30 words. Huh? So almost near that. So that is the importance of connecting the lungs to your pharyngoesophageal segment. Is there any procedure that you should do when you're doing laryngectomy to give a better voice, whether it's esophageal or tracheoesophageal puncture?
Myotomy, cricopharyngeal myotomy.
Yeah, very good. Any other questions are there? Dr. Raju?
Yeah. Anjali, can you tell me how to classify this stomal recurrence? And how do you manage?
Stomal recurrence is classified into 4. It is type 1 is recurrence, suprastomal recurrence without esophageal involvement.
The name of
Sisson's classification.
Okay.
Type 2 is supratracheostomal recurrence with esophageal involvement. Type 3 is infrastomal recurrence with mediastinal extension. 4 is with lateral extension into the great vessels of the neck.
How do you manage this stomal recurrence?
The post-op radiotherapy.
Which types are having better prognosis and which is having bad prognosis?
Type 4 have a bad prognosis.
What? I didn't hear it. I didn't hear.
The type 4 will have a bad prognosis.
Yes.
A type 1 good prognosis.
Type 3.
Type 3 mediastinal bad prognosis.
Yeah, 3 and 4 will have
Bad prognosis.
that. 1 and 2 you can try to treat the patient.
Dr. Anjali, what which sort of tumors or situations are there where there's likelihood of stomal recurrence?
If there is tumor seedling, incomplete, that is, if there is of level 6 lymph node, incomplete removal of level 6 lymph node can cause.
Level 6, presence, actually, removal or not, presence of level 6. Then?
A positive tumor margins.
You mean at the level of the new stoma? That means what? If you have to have a margin there that is positive, what does it mean? You have where is the tumor gone? Subglottic extension.
Subglottic extension.
Subglottic, you need not have a positive tumor margin, even having a subglottic extension, there is likelihood that they can be tumor, stomal recurrence. And any other reason? There is something that is
seedling when we are putting
this is not papilloma like that. I don't know whether tumor will do seedling. Anything else? Something to do with the timing of the tracheostomy. Is there anything like that?
Madam, if we have done a low tracheostomy.
No. Timing of the tracheostomy.
At the time of laryngectomy, we are doing tracheostomy. Chance for stomal recurrence is low.
Yeah.
Prior tracheostomy is the patient have more chance for
how much prior?
Recurrence.
Okay, so this you should read up. Okay, 7 days, 14 days. So we're doing a tracheostomy and then calling the patient after 1 or 2 weeks after 2 weeks after and doing the laryngectomy is not such a good idea because of this reason. So there are some studies which say this. But definitely the other reason, subglottic extension and level 6 pretracheal, paratracheal nodes being involved, thyroid being involved, all that is, there are chances of tumor recurrence, stomal recurrence.
Okay, if you are doing a total laryngectomy for this patient, what would you do for the neck?
There is no lymph nodes. Okay.
You said it is an N0 neck.
Yes, sir.
What are your options?
N0 neck. Based on the margin positivity and during the time of surgery.
Do anything in your case?
N0 neck, sir. Post-operative therapy.
Will you do an elective neck dissection?
Only glottis is involved. If there is on this during the time of surgery, if any frozen section.
So which all cases you will do an elective neck dissection? How do you decide?
A sentinel lymph node shows.
With laryngeal malignancy, you would like to do a neck dissection.
Positive lymph node. There is lymph node involvement is the.
The N0 neck.
After sentinel lymph node biopsy came positive, you want to go for an elective neck dissection.
No, laryngeal malignancy. What they are asking you is, what are the chances that T1, T2 and all will have neck nodes? Positive neck nodes, occult nodes. Maybe you have not detected, but it is there and you have to remove it. T1, T2, T3, T4. Glottis malignancy only, but T1 chances of lymph nodes are there, T1 and T2.
T1 lymph node positive only when there's T2 supraglottis.
Yeah.
Chance for lymph node.
Yes, you are thinking and answering. That is all you have to answer. If it has gone into supraglottis, if it has gone subglottis, chances of lymph node extension is there. Lymph node involvement is there. But as long as it's limited to the glottis, very unlikely, isn't it?
Yes, madam.
Because that is supposed to be the watershed area of the larynx, the glottis. No thyroid cartilage involvement, not gone into the supraglottis, glottis, not paraglottic space. Then there is like, not like, so that's how you have to answer. Okay, you just have to tell the answer, you know it. Okay, but once it becomes T3, T4 and all that, more chances that there will be lymph node involvement, isn't it? So then you have to say that as I will do elective neck dissection. That is a word. Elective neck dissection. You may not find it, but there may be nodes and you want to remove it because anyway you are opening the neck.
In a larynx case, which all levels you will remove? In a selective neck dissection, if you're doing it for an zero neck.
Sir, supraglottic extension, select removal of level 2 and 3. Subglottic extension. Level 2, supraglottis and glottis level 2 and 3. Subglottic
Level 2 and 3.
extension, we go for level 6 and level 4 lymph node also.
So you have to do 2, 3 and 4. No? What about in oral cavity lesions?
For in oral cavity, level 2 lymph node.
Oral cavity.
Only 2.
Or supraomoid neck dissection.
What is that?
Just think, supraomohyoid means which all levels are there?
Level 2, 1, 2, 3.
1, 2 and
3.
2 and 3, yes. What about if tongue is also involved?
Sir?
What if tongue is also involved?
cavity, if tongue is the epicenter of the tumor,
For tongue
which all
lesion,
levels?
for tongue that is supraomoid neck dissection. To level
Any
1.
additional levels here?
Two, 3. What is the next number?
Lower.
Yeah.
4.
4 also. Can you tell me some causes for inoperable neck disease? When you would say that this neck disease is inoperable?
So when there is prevertebral fascia involvement, in case tumor, in case the carotid artery or mediastinal involvement.
Yes.
If there is extension to
Any other? One more.
root of neck.
So the brachial plexus.
Oropharynx. Sir?
So the brachial plexus also.
Brachial plexus.
Near total laryngectomy in your case.
Hmm?
Can you do a near total laryngectomy in your case?
Near total laryngectomy, since there is only involvement of gross involvement of anterior one third, but there is posterior two third of the vocal cord is not healthy. And so we cannot preserve a normal, minimal normal vocal cord. So
What are the prerequisites for doing a near total laryngectomy? What all structure should be there?
so for near total laryngectomy and cricoid ring with an intact arytenoid, and at least a contralateral vocal cord, a 2/3 of the contralateral vocal cord should be normal. Post cricoid interarytenoid.
What is the other name for near total? Who was the one?
Bruce Pearson,
Mm.
Pearson laryngectomy, parsimony laryngectomy.
What is the principle behind near total laryngectomy? As you said, at least 1/3 of the vocal cord has to be.
No, we are making a biological shunt.
Myomucosal shunt
Shunt.
between
Between the esophagus, tracheostoma, and pharynx.
Any other questions, anyone?
Any questions from the audience?
Anjali, nobody is asking anything. So you have done a total laryngectomy. Patient has developed a pharyngocutaneous fistula. How will you know that the fistula has come and how will you manage?
Sir, if there is pharyngocutaneous fistula, we can see salivary leak through the suture line. And we can manage conservatively, that is giving tight dressing, and if daily dressing, tight dressing, and if within 2 to 4 weeks, if it is not resolving, we want to go for re-explore the wound and identify the fistula, and reconstruct the pharynx.
What are the types of fistulas? How many types are there?
Based on the size, 4 types: less than 2 centimeters, 2 to 4, 4 to 6, and more than 6 centimeters.
Depending on the length?
Less than 2 centimeters.
2 centimeters of what? Okay, you can read it. She is learning all these things. She is only second year.
Yes, a very good presentation and excellent presentation for a second year student. Even answering the questions, I have to say that. Congratulations to the student and also for the teachers.
All teachers are sitting there.
Yeah, that's what I'm saying.
There's
Very
one
good.
question, I
Second
think.
year.
There's one question, I think. Somebody's asking about pre-malignant lesions.
Yes, yeah.
You would like to answer that? Anjali, you would like to answer that? For the larynx.
Leukoplakia, erythroplakia, keratosis, dyskeratosis.
Of the larynx. What about papilloma?
No, it is. Juvenile onset papilloma is a benign. Adult onset papilloma is a pre-malignant condition.
Which type of, what is the type, subtype virus? HPV subtype?
HPV 16 and 18.
Lower motor neuron facial palsy. I don't know what is the question. Somebody has
I
said.
think that this patient has low motor, but that is a different discussion altogether, I think. So, yeah.
Yeah.
So, anything else?
5 more minutes to go.
Sir, can I ask one simple question?
Please, ma'am. Please. Yeah.
I know who is speaking.
So I'm Jayprabha from Trivandrum.
Ah, you switch on your video. Let me see you.
I have on the video, but
We can see. Please go ahead, ma'am. Yeah.
Okay, ma'am. Please.
Actually, what is delphin lymph node? Delphin node.
Prelaryngeal lymph node is also known as delphin lymph node.
What is the importance?
It is level 6 lymph node, but because if it is incomplete tumor, removal of the posterior delphin lymph node can cause stomal recurrence.
Anjali, what are the extrinsic muscles of tongue?
Sir, it is palatoglossus, styloglossus, genioglossus,
And
styloglossus, hyoglossus.
once more?
Palatoglossus, styloglossus, hyoglossus, and genioglossus.
Okay. What is the nerve supply?
It is supplied by a hypoglossal nerve,
All of them.
Except the palatoglossus,
Yes. What is it supplied by?
the vago accessory complex.
Right? Supplied by?
Vagus,
How?
vago accessory complex.
Yes, the pharyngeal plexus.
Pharyngeal plexus.
Can you tell something about the pharyngeal sutures that you put after laryngectomy? How to close the pharynx, the different ways and which material you use, how do you stitch, what is the conventional teaching,
So,
any newer methods available?
so we can pharyngeal closure can be done horizontally or vertically, and there are it can be closed in a single layer or 3-layered closure. For extramucosal continuous suture known as conal suture, and stoma, muscle and stoma is separated as an interrupted sutures. We can use PDS, Polydax.
Can you repeat that? What is the closure again?
Sir, it can be horizontal or vertical, and a single layered closure or a 3-layered separate closure. We are closing the mucosas, extramucosal continuous suture, and muscle and stoma separate as an interrupted suture.
What is a pseudoepiglottis?
Sir?
Pseudoepiglottis. And how can it become symptomatic?
Pseudoepiglottis.
Yeah, pseudoepiglottis.
No, sir.
That forms in the upper part of the closure. Yeah, it appears like an epiglottis. In front of that, it forms sometimes in some patients a diverticulum. Most patients will have a small pseudoepiglottis, but some develop a diverticulum in front of that, anterior diverticulum, because of which they develop dysphagia and regurgitation. Laryngectomy, post-laryngectomy. And how is the stomal closure done? How do you do stomal reconstruction? Sorry, stomal reconstruction.
Half meter
Sorry?
suture. Half meter suture.
Huh.
From skin to cartilage, back to skin. And
What is the ideal shape?
So,
What should be the ideal shape for closure?
a D-shaped closure. The stoma size should be approximately the size of the trachea of the fish.
Suppose you develop stomal stenosis, how do you treat that? Some of these patients develop stenosis, stomal stenosis. Yeah, how do you treat that? Trigger the stoma, goes partial stenosis. How do you treat that?
We can go for a either radial incision over the stoma or serial dilatation of the stoma. One technique. Other we can go do a radial incision over the stoma or setplasties.
Yeah, multiple setplasties.
What is the prognosis of T2 glottic cancer?
Madam, after radiotherapy, after radiotherapy, patient will have a 50 to 60%, 5 years survival.
That's all. 50 to
This is
60% for
5 years
T2 glottic. This is one of the better malignancies to have. 50, 60 is very less. You're looking at 85 and above, even for T2. What do you say? What do you call it? 80 to 85?
Increase in 5 years survival.
5 years survival, yes.
Hello. Hello.
Sir.
Hello. Hello.
Hello.
I think we will wind up now, and I request Dr. Kailash Pujari and Dr. Suja to say a few words on her presentation, and I, Dr. Raju, to give the vote of thanks.
Yeah, I think a presentation very nice. Knowing that she was a second year, quite surprised that she has done quite well. I shouldn't be surprised, but anyway, she's answered most of the questions that we've asked. So yeah, she's done quite well, in fact. Yeah, and this is hopefully a good learning experience for everyone who has participated. Right. The only thing is that one thing you have to read up on that follow-up. Follow-up is not a thing. Post-treatment. Yeah. The frequency and duration. But otherwise, a very good presentation. Congratulations. Yeah.
So, Dr. Anjali, I have already told you, I think your presentation was good and I like the way that you dealt with the answers. But you have to be a little more confident when you are answering. You know, sometimes we ask questions. When we ask the questions, you need not think that, oh, this answer is not. So that is why they are asking with it. So if you, so, and of course at PG level, what we require is we need a discussion from you. Okay, so sometimes like this patient treatment, many options may be there, but you should be able to tell us, okay, why this treatment is better than the other treatment as far as this patient is concerned. Okay, it is not as if, see, at UG level, maybe answers there's an yes and a no, that's sort of black and white. But at PG level, it's a little gray zone. So you will be able to, you should be able to discuss, even if, okay, this is what I am choosing, you should be able to tell us why you are choosing this, okay, over something else, some other method of treatment. and think, okay, maybe this is wrong. Mostly there is nothing like that wrong and right when you're discussing options, differential diagnosis, all that. So that is important. We want to see that level come from PGs. Whether are you able to discuss your answers, your patient, okay? But I think you are reaching there, and you have the knowledge. And of course, over the next year, it will really improve. So, and very good. And I think even teachers have also taught you well. So basically, when we hear the student answering, we always think of the teacher behind the student. It is not possible for the student alone to reach the place. So you're done well, and keep it up. And of course, an example to all the students who are listening also, how to answer. Okay. So thank you very much.
Thank you.
Thank you. First of all, I would like to thank Kailesh sir and Suja madam. It was a very good learning experience, I think, for all the postgraduates who participated in this program. Also, I would like to thank Dr. Anuraj and the organizers for this excellent platform. It's actually a very good medium for the postgraduate students to learn. And I would like to thank all the delegates, all the participants, the PGs who have participated, and all the teachers who have participated. And also my co-internal examiner, Dr. Sandeep, Nambudiri sir. Last but not least, our Dr. Anjali also, she did a very good job. Thank you.
Sandeep, anything?
I'd like to add something. I want to especially thank you. We all want to thank you because this couldn't have been possible if not for you. You had really structured everything. Thanks.
Or to Anuraj.
Yes, sir. Yes, sir. We can wind up, sir. Thank you. Thank you. It was a good presentation. Thank you, sir.
Thank you.
അഞ്ജലി പാർട്ടി നടത്തണം കേട്ടോ.
Thank you.